Okay. So, good morning, Tim.
Mhm.
How are you?
I'm good. Yeah. Yep. Very good. Thank you.
Is the sun shining?
It is. It's a beautiful day and lovely spring day here.
Absolutely the same here too. That's just
Mm.
wonderful. So, um, good morning, everybody. Good afternoon, maybe good evening, depending on where you are in the world. If you would like to let us know, good morning, David Bolton. Wonderful to have you. If you'd like to let us know where you are joining us from in the chat, that would be great. We love to see our international audience and see who's with us because it can be a little bit strange just chatting to a screen. So it makes us feel really connected to you if we can see who we've got. So, Veronica from Vienna, welcome. Eddie from Orlando in Florida, welcome, Eddie. Valentina from Slovenia. Alexia from Suffolk. Oh, it's going quick now. Oh, Andrew from Egypt. Amazing. Good morning. Oh, welcome, everybody. So great to have you with us. Thank you. Thank you for taking the time to join us today. So we're not going to hang around. We're going to kick off. We always run out of time. So I shall do my introduction so I don't forget to say anything. Just bear with. Let's get my script. Here we go. Okay,
Oh,
so
you're going to read everybody. I think there's a great mix geographically,
I
isn't there?
know.
So awesome. Great to see you all.
Yeah, great to see you all. We do love it that everybody comes from all over the world. It's amazing. So thank you very much for taking the time to join us. So, hello, and a very warm welcome to this Graded Motor Imagery webinar. My name is Joanna, and I am Director of NOI in Europe. And I am joined this morning by my very good friend and NOI instructor, Tim Beams.
Hello.
Morning, Tim. Tim has been a NOI teacher for nearly 20 years, and he has taught graded motor imagery to hundreds and hundreds of clinicians all over the world. Tim is an active clinician himself, specialising in persistent and complex pain. He is also co founder of an organisation called Le Pub Scientifique, which is an online education platform for clinicians to learn about treating pain directly from the people doing research and also leading clinical experts. So, Tim, I think, has dropped the link to Le Pub Scientifique in the chat. Please do go over and check them out. They have got some really, really great content. So, these sessions are all about giving you a taste of GMI and how to practically use it in the clinic. Some of you will have done a course already, and for those of you that have, these sessions are designed to reinforce what you've already learnt. But if you are new to graded motor imagery, this will give you a really good taste of what we cover in the core course. We have a course with Tim coming up at the end of April, and I will drop the link to that in the chat. So if anybody wants to go and check that out whilst the session is running, please do. And if you do have any questions, we'll be having a little chat about that at the end and giving you a little bit more detail about what you might expect if you were to decide to come on the course. So, just a couple of things before we get going. Tim and I are going to be talking for about 20 minutes. If you have any questions, please ask them in the Q&A or in the chat, and we will get to as many of them as we can. The recording of this session will be in our clinical discussion group on YouTube. And if you want to jump on there afterwards, you can watch it back. And please do like, subscribe, and share it with anybody else that you may know that will be interested. We'll also send you out a link to the session afterwards by email, just in case you can't find us on YouTube. Okay, Tim. So today we're going to be talking about ways to introduce and explain GMI concepts to patients who may be resistant to brain-based approaches. So let's kick off by could you give us a brief introduction to graded motor imagery and why it is so effective for so many different types of pain?
Yes. Hello, everyone. Yeah. So GMI, graded motor imagery, so much easier, isn't it, if you just abbreviate it to GMI? GMI is a treatment approach. It has three stages or steps, three parts to it. Those three parts are, first of all, left right judgment. So essentially, what you do during that is you are looking at pictures and you're guessing whether you're seeing a left or a right body part in that picture. So, for instance, you'll be presented lots of pictures of hands that are randomly presented, flipped over, turned, rotated, etc. And you're trying to guess whether you see a left or a right as quick as you can. And that gives us a bit of data. We'll talk about that in a sec. Explicit motor imagery is the process of imagining moving yourself, and then mirror therapy, and that's using a mirror to, essentially create an illusory experience that the reflection you see is of your body part that's obviously hidden behind the mirror, or if you've had an amputation that might not be there anymore but is behind the mirror, to give you a sense that you really are moving. So those three stages, those three steps together form what is called graded motor imagery. And there was a second part to the question, which is, why is GMI so effective for pain? I think it was
Such
it?
a broad range of
Broad range.
pain states.
Oh God. That's a question that we'd need to spend longer over, I think. But can I summarize it by saying GMI has been shown to be effective in particularly in the more challenging pain conditions. So things like complex regional pain syndrome and phantom limb pain. And what we believe, and we're starting to see in some pain states, is that benefit in the really complex stuff can be passed on to, I suppose, more common pain states. So things like pain when someone's immobilized from an injury, so they are in a cast or a brace. There is risk factors involved in being immobilized for long periods of time. So that would be something that we've found fairly recently, which would be great, wouldn't it? Because if we can limit the numbers of people that proceed towards this persistent pain state, and in that's a specific example of where we see a lot of people developing CRPS come from an immobilized state that's been really painful. So if we can reduce the risk of someone developing CRPS, even better. So yeah, so that's it looks like GMI can be effective for a number of pain states. I have to say that isn't broadly, like things like tendinopathies look like they don't respond so well for GMI. So there's definitely, it's not a let's just do this with everybody approach, and that's really where the thinking comes in, and where we want to talk about it, because there will be a certain group where features of GMI will be important and effective. Now, they might be important to assess so that we understand whether or not they're a feature of that pain presentation to start with, and then from that assessment we can understand whether or not we go ahead and we use GMI.
Amazing. Thank you. That was really clear. Very good. Thank you. Maybe you've done this already, but I was going to ask you about walking us through the three stages of GMI and with some practical examples of how each stage works. Do you feel like you've covered that? Because if you have, we can just move on. We always run out of time.
Well, look, summarizing it, we said left-right judgment. So that's often called implicit motor imagery. So looking at pictures, whether it's on a computer, an app, a magazine, a card. Explicit motor imagery is imagining movement, and mirror therapy. So using a mirror, practically doing the movement. So they're the stages. Yeah, I think we sort of described.
Yeah, I think we've covered that. So
Yeah,
that's
let's get
great.
into the nitty gritty of
Get into
today, which was,
it.
I think, was the sort of challenges that you come across, wasn't it?
Very
And
much so.
yeah, because
Yeah.
I think that this is a good subject for us to talk about, which is why we chose it. I mean, there was method to the madness, wasn't there?
Of course.
So I think many people who will be listening here, if you're a clinician, you'll have come across this. There will be some resistance when you start to introduce elements of GMI. You know, why would I look at a computer screen and guess a left or a right body part when my pain is here? You know, I've got it here. Why am I having to look at a computer? So,
Mm.
yeah, I think that that's a very real challenge. And I think one of the things that I mean, it's been a challenge for me as well over the years, but I think what we must appreciate is GMI was developed at a time in pain philosophy and understanding that was brain centric. It was the depths of thinking of the brain as the most important thing to understand in order for us to make sense of pain and to work with pain. So GMI was developed specifically as a brain-based treatment.
Mm.
So, getting into a bit of stickiness around that, I think is fairly understandable, really. Yeah, yeah. Whether or not we think that's the case now really depends on your perspective and how you view and how you make sense of pain, how you view and
Mm.
make sense of GMI as well. But I certainly, I mean, just to continue this thread, I certainly have experienced on several occasions resistance in different ways. I mean, resistance from simply someone. I've had someone walk out of a treatment, like in disgust. I mean, that's a good learning curve for me and what was going on. But I think actually there was a lot more going on than just me and the GMI as a treatment. But
Mm.
but look, that's a sort of an extreme, I think, reaction and defense probably as well.
Mm.
I've just had bafflement as well, and a little bit of anger and frustration, and then you have people who minimally intend towards trying it out, almost like they're doing it because they're sort of amusing you, but they don't. But there's like, okay, I'll do it, but I just don't think there's anything in this.
Yeah.
So that's look. I think that that's a really common experience for clinicians. And
Mm.
if you're someone experiencing pain and you're here because you want to learn more about it as well, it's important for us to have dialogue, have a relationship where if you think what the hell's going on here, you can start asking that question, and it's important to discuss it with the clinician.
Okay. So
Yeah.
um, these are the sorts of things that clinicians are faced with. Bafflement, doing things to please you,
Yeah,
walking out.
frustration, anger, yeah, you name it, absolutely. And
Where
then
do you go with that then, Tim?
yeah, well, and even
How
you
do you
get
handle that?
well, like these are all opportunities to learn, I think. So I mean, one of the things that I'm much more mindful of, having experienced things like that, is setting up the process.
Yeah.
So, when do you try it, and how do you try it? And these are really, really important considerations. So I look, one of the things, although this is how I do it, I'm thinking, is this how I always do it? I think it's pretty much how I always would do it, is that I would do it, I would just put an invite out, an invitation. Would you be interested in trying this out? It might feel a bit weird to begin with. I'll explain everything as we've done it. And it's like an invite. Let's try this out. And that might be my way of introducing the left-right judgments, for instance. So I'd say, look, I've got this app. It measures a few things we think we're going to be interested in, but I don't know for
Mm.
sure. Would you be willing to have a go? So an invite in, and you very quickly get a sense of how someone receives that.
That's a great conversation starter.
It's a good conversation starter. Yeah. And the nice thing about using the app and guessing the lefts and the rights is you immediately get data. So you get some feedback. How well did someone do? But you also get data, you get feedback on how they, felt about doing it as well. So both of those are equally important. And you are being,
Mm,
you, if you don't figure those two things out, then you've lost something immediately, which is really valuable. So the felt sense of doing this as a task is mega. And we've talked about this, the embodied state and learning,
yeah,
etc., in other senses, haven't we?
I love that, Tim. So that starting the process with an invitation and then actually collating data is a really positive thing often for the patient.
Yeah, I think we're in a sort of, it depends as well on the person in front of you, but we're typically in a sort of data-driven age, aren't we? So,
Yeah,
getting feedback immediately, we've already had a conversation about this in other ways, haven't we, this morning? But getting data immediately is quite
mm,
fun. There's a sort of gamification part of this as well. So,
mm,
it's good to get a bit of feedback straight away, and immediately it's something that you can discuss.
amazing. There's a really good question here from Sarah Hodgson, which I think would be very appropriate to ask at this moment. Sarah asks, how do we explain to patients that their left right discrimination test on their complex neuropathic pain state was more accurate and faster than on their affected side?
Hi, Sarah. Thanks so much for that, and yeah, I hope you're well. Simply, sorry, I'm trying to read the question there. It simply gives us data that is from what I'm reading into this, but is different from a sort of one way of interpreting or one set of data that we've got in the past. So let's just put this into some perspective, Joe. So for people listening, in the past, we thought that it was the data that we were getting back from people in pain typically showed someone being slower and less accurate when they were guessing their lefts and rights on their affected side. So it looked like that was the case. Now, when we start pulling this apart, actually, we see evidence that yes, that is true. You have some people who can be slower on the affected side, some people can be less accurate on the affected side, absolutely. Not always at the same time. So someone could be slower but have good accuracy, someone could have poor accuracy, but their speed is totally within a parameter that we'd expect to be normal. But we also see the exact reverse. So exactly what Sarah's saying is that you can see people on the affected side or the affected body part, because sidedness is something as well. So you can have changes in the results on through the entire side. So hand, back, neck, foot, etc. And it could be more accurate and it could be faster. I mean, it can only be accurate to a point because we can have 100%. We can't have 110%,
Yeah,
but you can have a better accuracy on an affected side. Yeah. And
thanks.
then there's a second part of the question, which is how do we explain it? Well, we need to try and make sense of what that data actually means. And there lies probably the second part of where we're going with this talk, which is what is left right judgment actually showing us?
Mm,
Well, we think that it does two things. We think that on one level, speed is a proxy for attention and the dynamic ability to attend either towards or away from a body part. And
mm.
should we try this out? So if I say, Joe, think of your left elbow. When was the last time you thought of your? I know where you thought I was going as well. I
Yeah,
think you
that's
were
not what
going.
he
He's
said
going to
before we came
say,
on this call.
yeah, he's going to say bum. Think of your left butt cheek.
Yeah.
So everybody who's listening in here, I've said, think of your left elbow. As soon as I say left elbow, you can bring your attention towards your elbow,
Yeah.
to greater or lesser ease. And if I say left bum cheek, you can bring it towards your bum cheek. And then if I go elbow bum, you get the picture. You can flex, you can be
Mm,
dynamic with the attention. And that's a good attribute, the ability to be able to tend towards, but also to attend away from it. And what we see in some people, Sarah's question is that some people have a heightened attention towards a painful body part. And that kind of makes sense. And there might be other elements that go with it. But essentially, that's an important feature of us to understand before we work with GMI.
mm,
Because what GMI traditionally does is it's trying to train that. It's saying, let's bring your attention towards this area, towards this area. So it's almost like saying left elbow, left elbow, left elbow, left elbow. Now, if your attention is already amazing at attending towards your left elbow, why make it better? So
mm,
Sarah, one thing that we see is if you see someone who is much, much quicker at being able to attend towards that body part, we probably need to think of other ways of applying GMI. So it might be that you train attention towards another body part, but then that depends on what you're finding in other body parts as well. So
mm, mm,
accuracy is a bit different, and for the purposes of us now, essentially what we have is it's like a planning. We think that the accuracy is a proxy for your ability to be able to plan, predict movements relating to that body part. I wonder whether, if someone has greater accuracy in a area, now that might be because they're trained. So a musician, a sports person,
mm,
etc., where they're really trained at, moving a particular part of their body. Now, from a pain point of view, that makes sense if someone has done a lot of training to predict, to, avoid moving or protect, or so there might be certain people who've done a really good job of practicing and figuring out how they move that limb to an example, avoid painful things or adapt to painful conditions. So that's one way that you might sort of that make sense of left right judgment. I have to say, Sarah, this is still something that is developing. We're trying to make sense of this, and it is really complex.
mm.
So
Yeah.
and it shows how important it is to individualize the treatment as well. So the original, GMI 1.0 20 years ago wasn't interpreting this. It was saying everybody come in, let's just see how you do at this test, and let's just practice it, and let's see what happens afterwards.
So to me, Tim, this is just demonstrating what we were talking about right at the beginning of the session, which was how much there is to it, and also like how you've given me a glimpse into what you do in the course in a lot of depth, like all these different factors, bringing them all in.
Yeah, yeah. And
Yeah.
just adding to that, yeah. So bringing attention to the unaffected side. Yeah, that's it. So what we want is, I mean, sort of recovery comes in here, doesn't it? Because I bet you've forgotten about your left elbow, haven't you, Joe?
Yeah. Yeah. Totally.
Yeah. So, or your left butt cheek. Yeah. So
Both of
you've
them
forgotten
gone.
about them. Like they've gone. Like under normal circumstances, we don't spend, supplementary energy thinking about something that we're not having to use. So, we're not wasting energy essentially. So, yeah, if you can train yourself away from attending towards something, that also says there would obviously go hand in hand other techniques that would be important for this person, which is sort of the realization of
Mm,
why is it that my attention is so strongly towards this affected body part?
mm. Mm.
Or the reverse. Why is it that I am almost disowning that? I'm unable to bring attention towards it. And then GMI has great merit here, is going, let's bring some attention there. Let's just plan how we move it. Let's get better at being able to do that. So the whole preparation side of it is really important for
Yeah.
those features in pain.
Yeah, that's a really great, Tim. Thanks ever so much. I think you've just given me a window right into how passionate you are about this, and also how you deliver it. I don't know if I did say this in the introduction, but Tim is actually co-author of the handbook with David Butler and Lorimer Moseley. So, he is one of the founding fathers of this.
Can I tell you a funny story about this?
You can.
So my daughter, well, she was showing me mirror therapy the other day that she'd learnt on Operation Ouch on the CBeebies, and she was going, "Daddy, look at this," and she was doing exactly that. And I was like, and I said afterwards, "Oh, that's really amazing. Where did you learn this?" "Oh, you learnt it there." I said, "Oh, well, that's funny because." I use that in my treatments with my patients sometimes, and I even wrote a book about it. She's like, "You did what?"
What, Daddy?
Anyway,
You did what, Daddy?
yeah,
Did she
yeah.
suddenly realise that you're quite clever after all?
Well, for about a nanosecond, she thought I might have done something, and then that was completely forgotten about very soon after. Anyway, yeah, show me, Dad. I'm going to show you, Daddy. Come on, stop talking about stuff.
Okay. I don't want to go on to something else because I think there was
Right,
just a couple of
sorry,
questions that
sorry.
I wanted to just make sure that we answered. I don't like it when we don't get to everybody's questions. I did them out of order because Sarah's yours was appropriate at that moment. So very quickly, Katie, absolutely nurses specialising in pain can attend the GMI course. We get a very broad range of professions of people on the GMI course specifically, because coming back to what we were saying about its flexibility and its applicability to so many different pain states. And also, Julia, we can affected people attend the course. Tim, I'll let you answer that one whilst I just go back and find the previous question.
Absolutely, yeah. So if you are, a patient of and interested, I mean, what better way of being able to help yourself than
Wow.
learning about what could be helpful. Yeah, yeah, yeah.
Yeah.
We probably have one or two people who are in pain or wanting to understand how to help themselves per course.
On every course, don't you? Yeah. Yeah.
Yeah.
Sometimes they are clinicians as well,
We,
aren't they?
we,
But
and sometimes they're clinicians as well. And I've got to say, like, if you're a clinician and you're listening to that, it demonstrates how invested some people are, and also the knowledge level that some of your patients will have is phenomenal. Not
100%.
because just because of me, but like people invest time and energy and really look and really know their stuff. So
Yeah.
yeah, yeah.
Um, and there was a question right at the beginning from Alison. She was wondering about chronic pain in the mouth nerve root.
I mean, look, that's a great question. Well, the first thing to say is we don't have an app, but some people have done a bit of work on this actually. And what they did is they were taking pictures of smiling or grimacing or moving your tongue and stuff like that. So, although there was a bit of research on this and looking at left right relating to the mouth and tongue and chin and stuff like that, it's not available through Noi. I don't know whether it is through any other channels, but what they showed was that there was a little bit of benefit from that. One of the things is using the mirror for the face, the pelvic region, the back. So in other words, axial body parts, you aren't using it in the same way. So although you're using mirrors to create feedback of movement or the sense of the body, you are doing it in a slightly different way. So you're applying it, but you're just adapting. So yes, it would absolutely be possible for facial pain, for sure. Yeah, very often for pelvic pain as well. And you can incorporate touch. For facial pain, we would incorporate things that, I mean, obviously function for the mouth, but also things like emotion and expression of emotion in pain can change in facial pain. So, yeah, getting some feedback of that, getting the felt sense of it as well in the body when you smile or you grimace or scowl or whatever it might be, yeah, is an important part of that process.
Thank you, Tim. Thanks for answering those questions live. I think we've probably talked a fair bit about the actual course. I would just like to say before we wrap up here, is there anything else that you would like to say about what about the course, the GMI course that we haven't already talked about, the benefits people will get from that, doing the whole
Um,
thing?
Sorry, I was just reading that question that just popped up as
Oh,
well. So, what's the benefit of the course? The benefit
yeah.
of being on a course is being with people and being able to share your thoughts around the people that you work with as well. So,
Mm,
look, you can go and you can watch our videos. We've done four, five, six of them now, haven't we? And you
yeah.
learn, you can read the book. You can read the research. What you get from going on a course is you get to be with people, think, discuss, share. And I think that's
Mm.
the value of going on courses, to be honest.
Very much so.
Yeah.
And yeah, our belief is we're very passionate about that when we have run a course, we don't just finish. That's what this clinical discussion is all about. So we have several other GMI videos on the YouTube channel on the clinical discussion channel, which the link is in the chat. Please do go on in there and have a look at some more of them. There's an introduction, there's some other deep dives that we've done into various aspects of GMI that will give you a really informed approach, a really informed idea as to whether this approach is something that you will find useful in your clinical work. And again, if you do decide to join the course, we're here to support you post course. So you can jump on as many of these sessions as you like live. And also, the other amazing resource that we have is the Facebook clinical discussion group, which is free. It's open to everybody. There are amazing clinicians in there. David Bolton is probably the main NOI clinic, the main NOI instructor who's in there supporting people in that group. There's I think nearly 3,000 people in there, and if you've got any questions, there's always somebody to answer your questions. So please do go on over and join that. And David Bolton, who is such an experienced NOI teacher and experienced clinician, is always putting content in there that everybody loves, everybody learns from, and there's always people on hand to help you post education, post reading the books, whatever, however it is that you would like to engage with NOI. So, oh, Sarah, thank you. Did you see what Sarah just said? She did the GMO course with you, Tim, last year. It was such a great course, and I'm a total fan. Highly recommend. Thank you, Sarah. We couldn't ask for a better endorsement
I
than
stop
that.
there.
Yes.
Retire.
Valentina, I have copied your question and we are going to answer that question. Do you want to answer that question very quickly, Tim,
Is
just
it a
before we
problem?
sign off?
Yeah, I just saw that as well. Is it a problem? Is it a problem if someone has trouble distinguishing left and right? The first thing to say is it is for some people. So some people, dyslexics, for instance, struggle being able to differentiate lefts and rights good well. Is that a problem for GMI? Well, it's a consideration. And if you experience that, then it certainly gives us some food for thought in whether or not we use GMI or how we apply it.
Okay. Thanks, Tim. Thanks so much. Thank you, everybody, for joining us in this live session once again. And there'll be another one coming up in about a month. So keep your eyes peeled for that. We absolutely love doing these sessions. We love having people here live. We love connecting with our community. And we love being able to share the knowledge that's in Tim's head. Fantastic. Thanks ever so much. Take care, everyone. Enjoy the rest of your day, and we'll see you next time.
Thank you. Bye bye.
Bye.